Good afternoon, everyone. Thank you for joining us today. Well, my name is Wendy Farthing. I serve as the Director of Community Integration for MAC Incorporated, the Maryland Living Well Center of Excellence. And before we get started, I just wanted to welcome everyone to joining us today. If you're returning to join this month, welcome back. And if this is your first time, we do have previous recording talks on our website that you can visit and access the recordings and any resources that have been provided. We are pleased to have a partnership with Johns Hopkins Geriatric Workforce Enhancement Program, GWEP, and MAC to provide professional development and community education. This monthly Lunch and Learn program asks the dementia expert to help address this growing health crisis. So this Lunch and Learn is a series that's intended for aging service professionals, caregivers of persons living with ADRD, and anyone with an interest in older adult matters concerning older adults. The series will provide an opportunity to engage dementia experts on topics regarding cognitive health, dementia care, caregiving, local services, and support. If you haven't yet, please mute your microphone. We have over 100 individuals registered for this webinar. I'm going to share next some brief resources that will be available to you all. We have some virtual statewide dementia workshops that are available free of charge on our website. You can access the link here on the screen. We provide caregiving workshops, building better caregivers, powerful tools for caregivers, as well as Savvy, which is a dementia workshop, and Advanced Savvy. We also have this dementia series recording. So if you access this link, you will be able to view previous recordings and resources. We are also linked into Find Help, which is a referral platform and resource platform that is statewide and nationally. We also have the opportunity to access 88 screeners. And if you have other topics that you would like some more information about, you can feel free to contact us and ask any questions that you'd like. For our next webinar, we typically are the third Thursday of the month. Next month will be the fourth Thursday. It's July 24th at same time, 12:15, and we'll be discussing managing difficult behaviors. I'm going to turn this over to Jane Marks, who's the Associate Director of Johns Hopkins Geriatric Workforce Enhancement Program and a nurse with the Division of Geriatric Medicine and Gerontology, and she will be introducing our speakers. We have the opportunity at the end of the presentation to have a Q&A. So I hope you enjoy the webinar. Thank you.
Thanks so much, Wendy. Welcome, everyone. We're excited for our next session here today with Dr. Galik. Dr. Galik, as you see, is professor of the School of Nursing and professor and chair of the Department of Organization System and Adult Health. She is a nurse practitioner and is also involved in not only education of future nurse practitioners and nurses, but also does work with older adults as well. And we've had the privilege of partnering with her over the years and have enjoyed that partnership with some of our work in education as well as in various healthcare facilities. Today, our talk is one that you've expressed an interest in: depression and delirium, understanding the difference and how they present in a person with dementia. So we will start our Ask the Expert session by going to the next screen. And the first question is, how does depression present in an older adult, Dr. Galik?
Thank you, Jane, for inviting me today, and a nice welcome to everyone who's joined us. So when a clinician is making a diagnosis of depression, they go to a manual called the Diagnostic and Statistical Manual number 5, and it had a text revision recently, and there's criteria for major depression. And what we see is that those criteria for major depression are the same as in younger people and older adults. However, in older adults, you're more likely to see some of the following. And these are all of kind of the different criteria, but you're more likely to see some of the following: that individuals have more bodily or what we call somatic complaints. So they may say things like, I just don't feel so good, or I'm really tired, or my legs hurt, or, my stomach bothers me. So the depression can have more physical complaints associated with it. Typically, older adults will have fewer complaints about depressed mood compared to younger people, but they are more common. It's more common for them to have what's called anhedonia, and that's just a complicated term that means a lack of joy in normally pleasurable activities. And in order to diagnose someone with depression, you either need to have depressed mood or anhedonia. And then 5 of kind of the other symptoms of what we see for depression. And they have to go on for a minimum period of at least 2 weeks and be sustained. Okay. Older adults also, there seems to be less seasonal impact in terms of their mood. You may have heard of seasonal affective disorder, where people may not feel as well in the winter months when the days are shorter and there's less light, but in the summer they're feeling better. There's less of that seasonal impact as we age. Not quite sure why, but that's just kind of what the research is showing. The other symptoms of depression that are common kind of across older adults and younger individuals are changes in appetite. It can be eating too much, not eating enough. Changes in sleep, where they might be sleeping too much or, again, not enough. Social isolation, and feelings of decreased self-attitude, so not feeling worthy or feeling guilty about things. Another symptom can be, and we'll talk about it in a few minutes, is suicidal ideation, and we'll talk a little bit about how to assess that. So an example, I saw somebody had a question about anhedonia. It's just a term. It's actually not a diagnosis, but it would be when, let's say, someone really likes interacting with their grandchildren, and you're noticing that they see them and they are happy to see them, but they're telling you, I just don't get as much pleasure out of that as I used to. So it's things that they used to love that they no longer are enjoying as much. I like to go to the beach. And I think if I were to be depressed, if I went to the beach and I didn't enjoy it as much as I usually do, that would be a kind of a big sign. So it's lack of joy in usually pleasurable activities. With older adults, you also want to think about the impact of grief and loss. So as we age, we may lose people who are close to us. We see some of our contemporaries developing health problems or passing away. And someone can be having symptoms that look similar to depression, but may be a grief response, or what we call an adjustment disorder with a depressed mood. So we always want to think about that as well, because we know that grief is kind of a normal process. There are screening tools that medical providers can use to help assess for depression. And some of these are actually embedded in electronic medical records now. And so you might be asked, if you're when you go to the provider, you see the nurse practitioner or the physician, they may ask you questions about depressed mood, and then this lack of joy in usual pleasurable activities. And that's called the PHQ-2. It's a screening for depression. And if you were to have one of those be positive, then that provider may go on to ask you additional questions 7 extra questions to further assess your mood. There's also a screening tool called the Geriatric Depression Rating Scale that's used for individuals who can self-report about their mood, and it's designed to hit at some of those specific symptoms that we see more commonly in older adults. And then there's also a really good screening tool called the Cornell Scale for Depression and Dementia. And this is helpful for someone who may not be able to self-report their symptoms of depression, but an informant, a caregiver, a family member, someone who knows that patient well may be able to provide that information. All of these instruments are actually freely available. The other thing that we need to think about is suicide risk if depression is suspected. So some of the risk factors for suicidal ideation: one, male gender. So men are more likely to attempt to commit suicide than women, although women tend to have more suicidal ideation. Also, if you're older and you've had a personal history of depression and suicidal thoughts or behavior, that's an additional risk factor, or having a family history, or having functional impairment. So you would want to assess someone's mood, ask them about, have they thought about hurting themselves or ending their lives? And then considering factors such as hopelessness, their impulsivity, if they have a plan, and all of these things would need immediate attention. There are some screening tools that providers can use to help to determine whether the risk is mild, moderate, or severe. One's called the Columbia Suicide Severity Rating Scale that can be used. It's also important to, if someone's living in a community setting, a continuing care retirement community, a senior public housing, etc., it's important because if something happens to someone, it may put it in other people's minds. And so the differences of how suicide presents itself in more institutional settings is it's more likely to have death by hanging or a fall from a height, possibly an overdose, whereas in private homes, it's more likely to be pills or a gun that's involved. So older adults, particularly older men, are one of the highest risk groups in addition to adolescents for suicidal behaviors. So we need to just think about that if someone has severe depression.
Next slide. So can signs of depression be mistaken for dementia in an older adult?
So yes, there can be overlapping symptoms between depression and dementia, and this is what makes it a little confusing to try to tease out. Some of those overlapping symptoms can be difficulty concentrating, difficulty making decisions, maybe not having as much energy as you used to. Also, isolating socially. You could be isolating yourself because of depression, or it's also possible that if you're having cognitive symptoms and you kind of don't want to put yourself in situations where people could identify that, you may isolate. You also might see a decline in function or activity. It's important to remember that dementia and depression may also coexist, and that having a dementia puts you at greater risk for depression. And that I think some of this is coming up in the next slide, but that having depressive symptoms may be kind of an early sign of a dementia syndrome that may be manifesting later.
Our next slide then. Can a person with dementia be depressed?
Yes, we know that individuals living with dementia are at an increased risk of depression. And somewhere, it depends, it tends not to be through the whole course of the illness, but rates vary anywhere between like 25% and 40% of people with dementia will eventually develop a depression in the context of their dementia. And as I mentioned,
Okay.
previously, that de depression symptoms, particularly if that individual has never had them before in their earlier life, can be kind of what we call a prodromal symptom or a heralding sign, um, or a risk factor associated with dementia. The important thing to remember, though, is depression is very highly treatable. And we're going to talk about treatments coming up in a minute or so, or less.
Thank you, Dr. Galik. So again, what is the treatment for depression as we move forward in an older adult?
So treatments can involve non-pharmacologic approaches, and kind of the major catch-all term, we think about psychotherapy. And what we might be thinking about psychotherapy, where there's a therapist and then a patient who may be laying on somebody's couch, that tends not to be, and talking about things from their childhood. That's really not the kind of psychotherapy we're talking about now. Instead, there's more of an approach, what we call cognitive behavioral therapy, where you're learning to identify if you have depression when you're having these kind of automatic thoughts. That because depression kind of changes the way that you think, and you may go to being kind of having these kind of negative thoughts that happen quickly. And this cognitive behavioral therapy helps you really to evaluate that. Is that part of that symptom of depression, or is this something that you can push back on? So, you might think, well, I'm never going to get better. This is just a terrible condition and I will never be well again. And this cognitive behavioral therapy helps to get you to, one, identify you're having that automatic negative response, and then think about, well, you know what? I just started treatment and, people seem to be hopeful that I'll get better. And so I need to give this a try and, move forward with the therapy. There's also interpersonal therapy, and this talks about, how people kind of relate to one another. Sometimes this is family systems therapy, and it's trying to build good and healthy relationships with others. You can also use a strategy called reminiscence, and this works particularly well with people who have depression and dementia, where you're drawing upon those older memories and that were positive and thinking about it. And this can be something that's guided with a family caregiver through pictures or, memorabilia, or just talking about a past event. The other thing that we tend to forget about, but exercise and physical activity is a wonderful treatment for depression, even as we age. If walking can be very helpful, even, riding a bike, if you have access through a senior center or other places, they have recumbent bikes that can be really comfortable. Also, the National Institute on Aging has free resources that you can get online with exercise programs that you can do that even can be done in a chair. And then the other thing that I think is so important is engagement in meaningful activity. So you want to be able to identify something that is meaningful to you and engage in it. So, it could be volunteering. It could be, if you were somebody who liked sewing, being able to do that, or joining a book club. So whatever was meaningful to you, kind of becoming involved in those type of things again. And so those are some of the non-pharmacologic approaches. Then there's pharmacologic approaches, and these include medications. And most of these medications act on a particular brain chemical called serotonin. And some of them act on another one called norepinephrine. And the idea behind the medications is in depression, we see certain decreases in certain chemical messages in our brain, serotonin, norepinephrine. And these medicines kind of help our body to keep what's supposed to be there longer. They're not without side effects, and so it's important to talk to your provider about what those may be, but many of them can be well tolerated as we age. I started working with older adults in the 1980s, and we had much fewer options then. And so, we live in a time now where there are a variety of choices. And even if one medicine in one class of medicines didn't work, perhaps one in another would be. Some of the common classes are selective serotonin reuptake inhibitors. These are things like sertraline or Zoloft. All these medicines have two names, fluoxetine, Prozac, or Lexapro is another name, or Celexa. And then there's the serotonin norepinephrine reuptake inhibitors. These are things like Cymbalta and Effexor. And then there's medicines called mirtazapine or Remeron. That particular medicine, if people have a poor appetite or they may not be sleeping very well at night, that might be a reasonable choice because it tends to help with appetite and sleep. And then there's one called bupropion, which is, its other name is Wellbutrin, and that can help people who have a depression with what we call psychomotor retardation, where you feel slow and you can't kind of get started, because that one tends to help energy. In cases of treatment resistant or very severe cases of depression, for where maybe you're worried about suicide, electroconvulsive therapy is a treatment option and can be used safely in older adults. The major side effects of this are memory, decreased in memory during the times of the treatments, but it is highly effective and even more effective than what we can do in terms of medicines.
As we move forward from depression, can you explain to us what is delirium?
Sure, Jane. So delirium is this clinical syndrome that's characterized by a brain dysfunction. So basically, there's something, often in older adults, it's a bad reaction to a medicine, or it is an acute medical illness that's causing a change in their mental state. And what we see is that there's this fluctuation. They may have a hard time paying attention to things. They might be really sleepy, and then that might alter with then having periods of time where they're hyperactive and maybe agitated. Um, People with delirium can display disorganized thinking. They may have these altered levels of consciousness. So they might be more groggy, or again, more agitated, or it might be a mixed picture. And if you've known someone who maybe has gone in and had surgery and received general anesthesia, and they come out, maybe they're more acutely confused, and they can't really attend to things, that's an example of a delirium. Some individuals can get an infection, whether that's a bladder infection or a bowel infection or a skin or a pneumonia, and that can cause a delirium. Or medications that act on our central nervous system, things that tend to be sedating, particularly narcotic pain medicines and other things, can also cause a delirium. So we are always thinking about this other cause that's a medical issue or often a medicine that can cause this abrupt change in mental status.
And So is it difficult to recognize delirium in a person with dementia? I mean, because it may not be clearly defined,
Yes,
you
it
know,
can. Yeah,
yeah.
it can be difficult because a delirium can be superimposed or basically on top of a dementia, and we can see how some of these symptoms can be similar. So the major differences between the two is a delirium is an acute illness. And so the onset tends to happen abruptly or develop gradually over a short period of time in terms of days or weeks. The onset tends to be gradual and progressive, and you may not notice changes day to day. Additionally, even in people who have very severe dementia, um, they can still, and even if they can't talk very well, they may be able to look at you and interact with you with their eyes or hold your hands or things like that. But a hallmark of delirium is when people have inattention and they're looking around the room, or they're not paying attention to you, or they get easily distracted, or they're sleepy. That might be more likely to be a delirium. Dementia tends to be a gradual progression, whereas delirium tends to have this fluctuating course. We also see functional decline is much more rapid in a case of delirium than what we would see with dementia.
Thank you. I'm sure that's helpful to many of us working in healthcare facilities as well as in the caring for those with dementia. So is there a treatment for delirium?
So the best treatment for delirium is to try to prevent it from ever happening if we can. And a lot of the prevention interventions are also the treatment interventions. So one of the keys is early identification of these symptoms of delirium. And that's easiest if you're a professional caregiver or a family member and you know that individual with dementia well, and you're seeing things that are just really different and they seem to be progressing more rapidly. You're seeing changes in function, behavior, and cognition, their thinking. Those are all clues that it might be a delirium. And if it's happening quickly and they're having these periods of inattention or lethargy or, really kind of significant changes that seem more abrupt. But to treat it as well as to prevent it, you're going to do some really basic things. One is to optimize sensory input. So if the individual wears hearing aids, make sure they're in good working order, the batteries are fresh, and that they have those hearing aids in. You want people to be able to wear glasses so that they're not misinterpreting things. Make sure the lighting is appropriate. At night, sometimes when people get up and need to go to the bathroom, they can be a little more confused. So having a night light on might be helpful. You want to minimize the use of medicines that act again on the brain and central nervous system. So things that could be sedating in particular. And particularly during this hot weather, it's important to hydrate because we're more apt to lose our extra fluid. So it's important to maintain our hydration. Dehydration is also a cause of delirium. You want to promote adequate nutrition and optimize mobility. So if someone's had an acute change, and let's say they're in the hospital, rather than spending all their time in bed, there's research to show that if you get people up early and mobilize them early, that they tend to do better and have less delirium and regain their function more quickly. You also want to do what you can to try to establish a regular sleep-wake cycle. If they're in the hospital, this can be kind of difficult because people are coming in at night to check blood pressures and maybe early in the morning to draw blood. But you want to try as best you can to establish time that's up during the day, minimizing naps during the day, and then providing physical activity so people are tired and able to sleep at night. And then the last piece is trying to identify early if there's an acute illness And then if someone has a chronic condition, you want to optimize the management of those chronic conditions. So people can even develop delirium if their diabetes gets out of control. That can affect cognition as well, particularly if they have an underlying dementia syndrome.
Thank you. That was very helpful. Oh, I love this. You're going to compare for us. I love this slide. Thank you.
Yes. So one of the most challenging things is to differentiate between depression, dementia, and delirium. And we've talked a lot about these things, but this is a little handy slide that you're welcome to keep that talks about how they are different. So in terms of onset, for depression and dementia, the onset tends to be gradual. With delirium, it tends to be more abrupt or sudden, where changes are happening more rapidly. In terms of course, depression and dementia tend to have gradual decline or gradual worsening. With delirium, there tends to be a fluctuating course and changes are happening much more rapidly. For attention, this is that individual's attention. For people with depression, their attention is intact, but their responses might be a little slower. With dementia, it should be intact in terms of their ability to pay attention and have good eye contact with you. With delirium, this tends to be disrupted. With functional decline, people with depression, unless it's very, very severe depression, can engage in their functional activities, but they tend to be a little slower. With dementia, there is functional decline, but again, it's progressing slowly. It shouldn't be an abrupt change. So someone who was normally able to make their bed shouldn't suddenly be able not, have trouble with that or can't do that. An abrupt decline in something, or if they can normally walk pretty well and now all of a sudden they're stumbling around and they're having difficulty and more of an abrupt decline, that's more concerning for a delirium. Lethargy, you might experience that with depression. With dementia, you tend not to see people be sleepy, but they may be apathetic, which just means that it's hard for them to get started to do things, and they may need a caregiver or another person to kind of start them on a task. And with delirium, that lethargy, it can be persistent or it can fluctuate between sleepiness and irritability or agitation. And then the last characteristic is psychotic symptoms. In depression, psychotic symptoms can happen, but only usually in severe cases of depression or a psychotic depression. So psychotic symptoms are rare. They can happen, but they're what we call mood congruent. So the delusion may be that nobody cares about me, nobody loves me, or that I'm running out of money, or things like that. Whereas with dementia, psychotic symptoms are a little more common, about 25%, typically in moderate stages. And they can be delusions, which are fixed false beliefs. Less commonly are hallucinations, which are sensory experiences without a stimuli. In delirium, hallucinations are more common. People may see things or hear things that aren't there, or they might even feel things on their body that are happening. So those are some of the ways that you can differentiate depression, dementia, and delirium. But when in doubt, it's always good to see your healthcare provider if you have a concern, if you feel that that individual you care for or love is not acting like they usually act. It's usually a good sign that you need to seek out some medical assessment to clarify that.
Well, Dr. Galik, this was quite informative, I have to say. I think many of us have, especially during COVID, certainly experienced those that work in health facilities, caring for persons with dementia that have experienced depression due to the lack of ability to be around loved ones, as well as episodes of delirium for those that did get sick. So this kind of pulls a lot together for us. I was just wondering if there are other questions or comments that anyone would like to make. You're welcome to unmute yourself and ask, or if you want to write it in the chat, happy to do that as well. I know it was a lot of information, but I think so useful, and I love that chart.
We had a question that can someone have a combination of the three types of depression, delirium, and dementia?
Yes, it is possible. And I would say the most important thing to treat when all three things are happening is really to try to identify that cause of delirium, because delirium is highly associated with what we call morbidity, which is death, and mortality, morbidity, which is sickness, and mortality, which is death. And so the longer that a delirium goes on and is undetected and not treated, the more risk that person runs in terms of having health complications and even dying. So delirium is always the priority.
Thank you, Dr. Galik. Does anyone else have any questions or comments? You're welcome to unmute yourself or type it in the chat.
There was one question in the chat about anhedonia, and the question is this a condition that has been more recently identified? It's actually not a disorder in and of itself, but it is a symptom that's highly associated with depression. And so, but it's been around for a long time. Often, I think it's come up more recently in terms of older adults because they're less, particularly a population who may have gone through challenging times when they were younger and wars and all of those things. They may have learned, the pull yourself up by your bootstraps mentality, and, where you're not supposed to say that you're depressed. I think things have changed with later generations, but they may endorse saying, I'm not depressed, but I just don't feel like myself. Something's not right. Something's wrong. I'm not enjoying things as much as I used to. I'm not quite sure what it is. And that can be highly indicative of depression.
We had another question, or in a comment that someone's husband experienced constipation, and there was a great deal of confusion, and many of the delirium symptoms were present.
Yes. So if you have constipation that is untreated, it can start to trigger a delirium, and can even, if it's left untreated, result in a bowel obstruction, which would then give you even worse delirium. So one of the things that I do when we're seeing changes in someone where we suspect a delirium, ask about the last bowel movement, try to assess if that person's having pain. They may not be able to tell you, but are they kind of like rubbing something, or is holding their stomach, or if something's happening, or look for changes in their sleepiness during the day. Are they sleeping a lot more? And look for changes in function as well as in appetite and getting around those. And delirium can be caused from pain, from medicines, from constipation, from dehydration, from infections, from uncontrolled blood sugars. And so it's good to work with a medical provider to help that person ask different history questions that can help tease all of those things out.
I think that's such important information, and especially as you mentioned during this heat season, fluids are important, and more so important if you do have a history of constipation.
Yes.
I think some of our patients with dementia may not drink because they may not be thirsty or realize what they're to do if they are. So encouraging those fluids.
Yep. Fluids, mobility helps to prevent constipation. So getting people up and moving as best they can, drinking plenty of fluids. And then if you need to, there are, safe laxatives that you can use over the counter that they're called osmotic laxatives. Miralax is an example of one, but it helps to pull liquid that already exists into your bowel to soften things up so it's easier to move things along, as they say. The other thing is medication. Certain medications can cause constipation. And so you want to, if somebody started a new medicine and you're noticing problems with constipation, it's possible that that's a side effect of the medicine.
I think that's a great point to bring up, only because I just had someone have an experience that started taking Tylenol PM. So I think being aware of over-the-counter medicines and what they contain and how they could impact cognition or delirium as well.
Yep.
I did share in the chat the link for registration for future webinars, as well as access to this talk and previous ones. On the website, you will see that it had the third Thursday as the date. We changed that today. It has not been corrected on the website, but the next one will be on June the 26th, Managing Difficult Behaviors.
Wendy, I think that's July.
I'm sorry, July 26th.
I think it's the 24th.
24th. I pulled the wrong slide up. You're right. The 24th. Woo, pardon me.
All right, Wendy.
July 24th, Managing Difficult Behaviors. And that will be fixed within the next day or so on the website, and invites will be sent out for that as well.
Well, I think this has been a great session. Dr. Galik, thank you so much for your time and energy in putting this together and helping us. And we look forward to inviting you back in the future.
That sounds wonderful. Thanks so much for inviting me. And everyone, please take care, stay cool, and hope to see you again in the future.
Thank you.